So, sorry attendees that are here. We have three people that are joining us, and so Diane's screen is up, and we are going to get started. So sorry for the delay. I'm not sure exactly what happened, but we're going to get going and talk to you about the indicators of Osteoporosis Canada and what it takes to be an effective FLS. At the end of this presentation as well, there's going to be a little survey that is going to give you a chance to give us some feedback. Excuse us for the late start. Also, if you haven't viewed our FLS website yet, it's located within the Osteoporosis Canada website. If you look here on the screen, you're going to see in blue font the website for FLS. So feel free to check that out, and there's lots of great information on there. We, as an FLS across the country, try to provide a variety of services, and they include a toolkit that's available from the website that has a wealth of information. We also have a registry that lists all of the 46 sites that are so far existing for FLS in Canada. We send out a regular newsletter called The Liaison, and we are also more than willing to support any sites who are hoping to get a start on a new FLS and with our free consultation services. Many of our resources are available in French, and we hope to continue to develop more of them into French. We also regularly conduct webinars, and today we're going to hear from Dr. Diane Theriault. So I'm going to stop talking, and she's going to start.
Okay, so sorry again for that technical glitch there that caused us to start a little late. So last webinar, I talked about the essential elements, and this webinar is sort of the part 2 on that. So what we're going to look at today is the need for the FLS indicators, the Canadian reality, and that's going to be interspersed within the presentation. We're going to go over Osteoporosis Canada's FLS indicators, and then I'll just give a couple of examples here and there. So I'll first start by refreshing everybody's memory on the fact that we have a huge care gap after the fracture. This is data from the province of Quebec, and this is looking at women over 50 who had suffered a fragility fracture, and 15% got offered osteoporosis treatment, 5% had a BMD but were not started on treatment. But the most important part of that pie is the 80% in purple who received absolutely nothing for osteoporosis. No screening, no diagnosis, and no treatment. And of course, fracture liaison services are trying to close that care gap. The essential elements that we looked at the last webinar, I'm not going to go over them, but the last little bit of my presentation was going over the 8th essential element, which is the need for the FLS to monitor its own effectiveness. And this is such an important component that we have devoted an entire booklet on this. And this is a publication that we just put out last year. So we're going to go over this, but let's go over first why we need the FLS indicators. So this is the definition of a fracture liaison service. And in a fracture liaison service, there needs to be 3 key things that happen, which is first off, the identification of the patients. Then the patients need to be investigated in order to determine their fracture risk. And the final one being to get the patients who are at high risk initiated on treatment. And although we don't have any set benchmarks yet in terms of how good an FLS should be at each one of these components, I think most of us in this field would feel that any FLS that was super good at identifying and investigating and treating, if they reach 80% at each of these individual levels, that would be a pretty good FLS. And the fact is, we know that there's going to be some patients left behind at each of these steps. We'll miss a few at the identification piece, A few patients won't go for the investigations they need, and a few patients won't be able to be started on the treatment they need. Um, so let's see how that would rate if an FLS was 80% effective at each of those components. So we're going to start with a fictitious group of 100 patients, and for argument's sake, all of these patients are at high risk, and they would all be deemed in need of osteoporosis treatment if they were as per our Osteoporosis Canada guidelines. So if the FLS is 80% effective at identifying the patients, well, 80% of 100 would mean that 80 of the patients would be identified or captured by the FLS. And if they're 80% effective at the second eye, then 80% of 80% would be 64 patients now. And if they're 80% effective at getting them started on treatment, now you're down to 51. So this pretty good FLS that is doing not badly at all is still at the end of the day leaving half of the patients behind. Now keep in mind that that 51%, that's like threefold improvement compared to what's happening currently. So that's not a bad result, but obviously there's room for improvement. And the fact is that if the FLS could improve at any one of these levels, they will reach a better outcome. So for example, if they were 90% effective at identifying all the patients, then that would change the results from 51% to 58%. And the same thing here is if we improve the effectiveness of the third eye, that would get the same result. But imagine if we could improve to 90% at each of the three eyes, then you end up with 73% now of the high-risk patients being on treatment. That's a huge improvement. So obviously, in healthcare, we're always trying to improve things, but because there's so many steps involved in this particular instance, it's important for the FLS to be able to measure this. And it's obvious that no FLS is going to reach perfection. So what are we really trying to do? Well, we're really trying to make sure that 100% of the fracture patients receive the fracture care they need. If you want to look at it from the other side of that perspective, what we want is to leave no patients behind. Now, the bar that we have to go beyond at the FLS is set quite low because status quo is such that less than 20% of the patients receive the care they need. If an FLS sets itself up, does all of the right processes, that is, that they set up with all of the 8 essential elements, this will definitely increase the proportion of patients who get the appropriate osteoporosis care quite significantly. But it's still only going to get part way up. So to get higher up, there is a need to do outcome measurements to try and do these PDSA cycles, which you're probably all familiar with, but this is an ongoing process. The Plan, Do, Study, Act cycle means that you plan a change, you implement the change, you study the results that you get, you analyze them, and then you act to improve upon it some more. So we will look at a few examples that will have used that as such. Now, the fact is that the PDSA itself is helpful for the individual FLS, but at Osteoporosis Canada, we're looking at it at a much better, higher level as well. So as all of the FLSs do their PDSAs, over time they all improve, and the standard will improve over time. And in fact, it's a fact that if you're a fracture liaison service and you're implementing in 2017, the standards are way higher now than if you implemented an FLS, say, in 2000 or 2005. Over time, the FLSs have gotten better and better and better at what they do. So this new document that we put out late last year is really intended as a guide for the Canadian FLSs in their processes doing the PDSA and in their continuous quality improvement. But it's also meant to hopefully get all of the Canadian FLSs to use the very same indicators so that we can compare each other. And this is not about being a contest or a competition. This is about FLSs learning from each other. Every FLS has strengths and weaknesses. And if you could learn from another FLS's strength and carry that forward to your own FLS, that's only going to benefit the patients. Ultimately, I think at Osteoporosis Canada, we'd like to start setting benchmarks for FLSs. So is it good enough to capture 80% of the patients, or should it be higher? So in terms of, we don't really know what the benchmark is, and no organization has set an actual benchmark for FLSs yet. But I think it's time for us to sit down and say what's acceptable, what's better, what's exemplary, so we can set some benchmarks as we collectively measure the same things. By the way, this is not Osteoporosis Canada being elitist. Every single national and international guidelines or standard documents for fracture liaison services recommend that the FLS should do measurements of its own effectiveness and do study X cycles. So that's the fact in the International Osteoporosis Capture the Fracture program. It is a fact in the National Osteoporosis Society's FLS guidelines in the UK, and it is also part and parcel of the standards for fracture liaison services out of New Zealand. So I'm going to start up with one example here. So if we have an FLS that sets up at a hospital, and its intent is to identify all of the fragility fractures and to ensure that they get the bone density test that they need and that the high-risk patients are on treatment. So this is this program, and this look at its first year data. And in its first year, it's identified 60 fragility fracture patients. They managed to get 55 to go for the bone density test. And of those 55, 50 of them are deemed to be high risk and in need of treatment. And the FLS was able to manage to get 48 out of those 50 started on treatment. So they claim that 48 out of 60 patients are on treatment, so they're 80% effective. And the important lesson there is that there is something that is missing from this entire equation. So although this looks like a perfect FLS, and actually better than most FLSs could be, the fact is what's missing is you don't know how many fracture patients that hospital sees. So if that hospital sees 600 fracture patients a year and the FLS has only identified 60 of them, then that's not, the care gap is still alive and well at that hospital. Nothing much has changed. Okay, so here's 3 examples. So this is our example 1 that we saw before. Starts with 600 patients, ends up with 48 on treatment. But these other 2 models, you can see that they're very different. So they all start the same place, they all end up at the same place, but I think you can appreciate that the weak spots are very much at different locations. And so it's important for the FLS when they're monitoring their outcomes, not just to look at the bottom number, but also at each and every number so that they can focus on the areas at greatest need for improvement. And by the way, I should say that example 1, if you look at that example 1, 600 patients a year seen at the hospital, but the program here only sees 60 of those fracture patients. They do excellent care for those 60 patients. I would submit that that's pretty much close to what the average excellent osteoporosis clinic might see, because the clinic only sees patients that are referred to them. It's not an FLS by definition because they don't do systematic and proactive case finding. But you could see how their real weakness is the fact that they don't do that proactive case finding. Okay, so let's use another example. So this is example 1. You can see that they both start with 600. This one has only that big weak spot at the identification piece. And this one, they have a slow trickle down of patients at each step. I think you can clearly see that example 4 is almost 6 times more effective than example 1. So this is a much more effective FLS for sure. But then it is a matter of picking the right denominator. So if you say 48 on 60 is the way to measure it, and then the other FLS measures itself compared to this, well, obviously they didn't compare themselves to the right denominator because we know this one's more effective than that one. But even if they compared to the same denominator, okay, so 300 over 500, now it's still not showing up as good as this one. So it's not just about having the same numerators and denominators. It's about making sure that it's the right numerators and denominators. Otherwise, the FLS won't be showing the right results. So when the task force was struck to develop the FLS indicators for Canada, they had some clear guiding principles. So the first one was that most FLSs are under-resourced. Their staff are busy doing the clinical work that they need to do. So the FLS coordinators are seeing the patients, organizing the investigations, communicating with family doctors, all of which takes a lot of time and all of which must happen. And so we did not want to put a whole lot of focus on the FLS all of a sudden collecting huge amounts of data. So it was important that the data that we recommend be collected to measure these indicators should be as minimal as possible. It was also clearly identified that we needed to have indicators that would at least independently measure each of the 3 I's, that the numerators and denominators would be very clearly defined so that if it's measured at FLS A and it's measured at FLS B, we know that they're both comparable because they're both measuring the exact same thing. Now, this one is a harder one to understand, this intention to treat principle. The intention to treat really means that it's the intent of the FLS to identify all of the fragility fractures. And it's also the intent of the FLS to make sure that all of the patients they identify have the proper investigations they need to determine their fracture risk. And it's also the intent of the FLS to clearly start treatment on the high-risk patients. That's all as per guidelines. But the intention to treat principle is a higher level principle as well. It's used a lot in research, and it's always making sure that nobody is excluded from the list, no matter the reason. So I don't want to go into the details of this, but that is the principle that we wanted to use for each of the 3 I's. So for the first I, the second I, and the third I independently. And I've put here that the first I is the trickiest, and I'll go over that a little bit. But the other guiding principle was that the task force was asked to make sure that the indicators they would come up with would be adapted to the Canadian reality, and that is that it would be meaningful to our Canadian FLSs. So the first I being the trickiest, I gave you the example, and I hope you could see that it's so easy to think that your model is so effective, but yet you've missed the boat completely on the first eye. I always call it it's the invisible eye. You don't think you need it, but you do. It's the hardest one to measure, and it's easy to completely forget. And the first eye is the one thing that really differentiates FLS from any other osteoporosis program, such as an osteoporosis clinic, for example. So it is important that it be measured. So about the Canadian reality, all of our FLSs, we have 46 FLSs in Canada right now. All of them are located in orthopedics. And as you can see, 27 are in outpatient clinics only, 10 are in inpatients only, and only 9 of the 46 are combined inpatient and outpatient FLSs. So to be clear, 80% of the Canadian FLSs are currently limited in scope. They can either target the patients in inpatients only or outpatients only. So that is an important Canadian reality we had to take into account. Okay, so when we put the FLS indicators, we certainly had a great big long list that we could recommend. And since we had worked on all of them, we did mention all of them in our brochure. But in terms of being minimal, we identified the ones that we called core indicators as the absolute need to do by any FLS. So some demographic data, the first eye, the second eye, and the third eye. Anything else, and we do have that included in our document, is elective, so to speak. But these ones are the ones that are absolutely critical to do. So in terms of the core demographic data, you can certainly collect all kinds of data on the patients that are enrolled in an FLS, but we limited it, remember we're trying to be minimal, we limited it to age at the time of fracture and the fracture type. And here you're going to hear me talk a lot about the hip, wrist, shoulder, pelvis, or spine. Those are the fracture types that the task force decided that we needed to absolutely capture. And there are two reasons for that. One is we want to stick with the Osteoporosis Canada guidelines. So the Osteoporosis Canada guidelines do specifically mention that we need to exclude hands, feet, ankles, and skull fractures. But on top of that, there is a Canadian chronic disease surveillance system, and there was an osteoporosis working group that made a recommendation in terms of the fractures that should be surveilled in Canada, and they are those 5 fracture types. And indeed, those 5 fracture types are the 5 fractures that are most likely to come back with new fractures. So they're the most predictive of having secondary fractures, as opposed to hands and feet, which there's very little predicting future fractures. So is there any information that can be had from just looking at the patient fracture types? Well, I'm going to compare, this is all actually true data. So this is St. Mike's data, and this is published. And we're going to go through 3 hospitals. The task force actually looked at some prototype data in order to see how helpful some of this data might be. So you can see at St. Mike's, you can see wrist, hip, shoulder. St. Mike's in their publication, they excluded pelvic fractures, but they're not a huge number of fractures. And so you can see here how they're distributed. But the big 3 are those 3, and you can see where the percentages are. And in fact, if you look at data published from the UK, for example, in the FLSs, you'll see that same kind of thing. Now, St. Mike's is a combined inpatient, outpatient FLS, and so are hospitals A, B, and C. So when the data was looked at for hospitals A and B, you can see that it's amazingly how close in terms of proportion. See? Fracture populations, as a general rule, they'll fall in that same ballpark right away. But this is what was found in Hospital C. And I think you'll see that there's definitely a discrepancy in terms of how their numbers look. Now, obviously, it's not that they found too many hip fractures. You can't create fractures, okay? But what is probably more likely to show up here, or what this seems to suggest, is possibility that there may be a problem in the outpatient settings, because the hip fracture patients tend to be identified in the inpatients. Not all of them will be coming back to the orthopedic clinic, and very few wrist fractures or shoulder fractures ever get admitted to hospital. So even just looking at the fracture types might actually give a clue to the FLS where their barriers might be. So here's the overview of the core FLS indicators. As you can see, there's a numerator and a denominator for each of the first, the second, and the third eye. But I want to spend a little time on the first eye because it's a little tricky. So the first eye numerator is the number of fragility fracture patients enrolled in the FLS within 6 weeks of their fracture. And the patients must be over 50, and we're limiting this to the hip, wrist, shoulder, pelvis, or spine. Now you see the denominator here? I've got a big question mark. And that's because we typically don't know how many fractures are seen in a hospital. Very few hospitals can measure accurately anything but the hip fractures. And this is not just a Canadian problem. This is a worldwide issue. So in the UK, they looked at this and they said, well, the only accurate number we have is hip fractures, because we can't really say for sure how many shoulder and wrist and pelvic fractures. So we're going to just hinge our denominator on the hip fractures, and having looked at large data bases from fracture liaison services, they felt that the number was probably close to hip fractures times 5. And that's the denominator. In New Zealand, they looked at a slightly different database, but they still ended up with the same conclusion of hip fractures times 5. Now, the database they're using is, well, this is the database that they're using for the UK, and they're including hand and feet fractures and ankle fractures. So obviously for us, we could have chosen to go with hip fractures times 5 as well, but we had to adapt this to the Canadian reality, which said that we should exclude hand, feet, and ankle fractures. So we had to exclude those fracture types. And we had to also take into consideration that, well, not too many of our FLSs are both inpatients and outpatients. So we had to come up with a different denominator for outpatient-only FLSs, for inpatient-only FLSs, and for the combined inpatient-outpatient FLSs. So we had to remove hand and feet and ankles, but we also removed some of the other fractures. We only kept radius ulnar, hip, humerus, vertebral, and pelvis. Those are the ones we kept because they're the ones recommended by this Canadian surveillance system. So we did end up with a numerator that's fairly the same for all the FLSs. It's slightly different for outpatient-only FLSs, and I won't go into the details of this, but here are the measurements as per our databases, and we did that with both the UK databases that were available, as well as using the St. Mike's database. They have 11 years of data, and this is the closest we could come. Now, on these multipliers, we actually went a little bit generous. We wanted to avoid a situation that any FLS, if we made this too tight, we could have an FLS identifying 120% of the fractures that I present at that hospital. So we move that a little bit higher. So we know that no FLS will ever reach 100%. So it's up to us to set a benchmark. So it's going to be hard for NFLS for this, but the fact is we're all being measured on the same tough denominator. So let's go over them for a minute. So this is the denominator for the first eye. It's the number of hip fractures times the multiplier that's specific for the FLS type. And the numerator are the fracture patients seen within 6 weeks of their fracture. Now we want to keep this as minimal as possible. So the denominator for the second eye is the same number as the numerator for the first eye. And in terms of the numerator, it's the number of patients that have their fracture risk completed within 3 months of their being enrolled in the FLS. Now, we also require the FLSs to differentiate the patients as to whether they're low, moderate, or high, because it's only that last number, the high-risk patients, who will become the denominator for the third eye, because they're the ones that clearly need osteoporosis treatment. And this one is that the patients should be started on treatment within 6 months of their being enrolled in the FLS. Now, I want to spend a little bit of time to explain that concept of intention to treat. So this is very clearly, this is all of the high-risk patients. They're all going to be in the denominator, every single last one of these. Now, why could they be in the denominator but not end up in the numerator, because they're not counted in as having been started? Well, here are some reasons. It could be that the patient has decided not to start treatment despite the FLS recommending it. It could be that the patient, yes, was in favor of starting the treatment, but the patient's family physician had decided to recommend to the patient against starting treatment. The patient may have too many contraindications, have to be too sick and not be able to start treatment. The patient may be lost to follow-up to the FLS. So for example, Mrs. Smith did go for a bone density test. The FLS got the results. The bone density is not good, and the patient's confirmed to be at high risk. But in between the time you get those results and the time you try to get a hold of Mrs. Smith, she can't handle it at home, and she's moved in with her daughter, who lives 4 hours drive away. So you can't reach that patient. If you can't reach that patient, you cannot confirm they're on treatment or not. They could be on treatment, they could be not on treatment, but they're not going to be in your numerator because you could not reach them. And look at this one. Your patient may have died in the process. So they got the BMD all right, but they're never going to start treatment because they died in between. So those patients are still in the denominator, but will not be in the numerator. That is all part and parcel of that intention to treat principle. And it doesn't matter that it almost sounds like it's not fair. It doesn't matter because every FLS will be measured on the same denominator. So if you had one patient die in your FLS, it's almost a guarantee that other FLSs have patients die in them as well. And it won't matter why the patient declined treatment either. So here are some reasons why the patient may decline treatment. Well, maybe the patient's not convinced to have fragile bones. You know it, but unfortunately the patient could not be made a believer of that. The patient might think that the fractures cannot be prevented by osteoporosis medications. In other words, they don't believe that our osteoporosis medications don't work. The patients may have overblown misconceptions and fears about osteoporosis medications, or the patient may not have the funding or the insurance to cover expensive medications. It doesn't matter. It's not about a patient's right to refuse treatment or not. We all agree that it's a patient's right to refuse treatment. But we believe also that most of the patients who refuse treatment in this field, it's because they're not informed enough. They don't have a good, clear understanding of how serious osteoporosis is, how serious another fracture may be, and how effective our medications are, and how safe our medications are. So it's not a matter of it's the right thing to allow the patient to decline. Of course, it's the right thing. It's their right. But it's not the patient that we're measuring with this. It's not the FLS coordinator that we're measuring with these indicators. We're measuring the FLS, and we're measuring how many patients are still being left behind. And it doesn't really matter what the reason is. So the FLS indicators, they're not a reflection of how good or bad the FLS coordinator is. That should never, ever even be considered a consideration. It's all about measuring how effective the FLS is. And if you want to look at from the other end, how many patients are still being left behind. So how much extra work you need to do to capture those last few left behind patients. The barriers to the treatment, they're typically not intrinsic to the FLS at all. They're typically extrinsic barriers. For example, that patient who can't afford their medication, that's not the fault of the FLS. Okay, so, but it's still part and parcel of how the FLS would view things. If the problem is that the drug's not covered, then maybe we need the drug covered. So here's the case study, and actually I'm taking case study A from our booklet on FLS indicators. This was an inpatient-only FLS that focuses exclusively on hip fracture patients. So they identified 81% of the hip fracture patients. If you're a hip fracture only FLS, you get a free pass on the second eye because patients who have a fragility fracture of the hip after the age of 50 are automatically known to be at high risk. They don't need a bone density to tell us that. So they get a free pass there. But see where their weak link was? It's really the fact that they're having a hard time getting the patient started on treatment. So this FLS, it's a fictitious one, by the way, is doing their PDSA. They've done the step 3, identified their weak link, and they propose to act. So they look at what the barriers to initiating treatment, and they do find that one of the barriers is that in their province, certain osteoporosis medications that would be the best options for their patients, who are mostly elderly patients with broken hips, are not covered by the provincial formulary. And they also identified that the local family physicians are quite misinformed about the benefits and risk of osteoporosis medications. They'll often get a letter back from the family physician that says, well, it takes 5 to 10 years for the osteoporosis medications to work, but my patient only has a couple of years left to live. And of course, our drugs do work within 1 year, so that is misinformation. Or sometimes the family physicians might think that there's more side effects in older patients than in the younger patients from our drugs, which that is not true either. So, in terms of what they're going to do to try and change this, well, they're going to approach the provincial funded drug plan. They will try to connect with the administrators to make a pitch to see if in the elderly patients that break a hip, if certain drugs could be added to the formulary so that they would now be covered on their provincial insurance plan, the seniors plan. In terms of the local family physicians, they've decided to develop a fact sheet on management of osteoporosis in the elderly and see if that changes the perception in the community. So again, this is a fictitious case, but we would hope that in a year's time after they implement those changes, they do another set of measurements, and hopefully they'll see that they've had a significant impact on that third eye. So that's the purpose of doing those plan, do, study, act cycles. And by the way, this is forever. Okay, this is not a one-time thing. You do this, you remeasure, you try to improve, and you try to improve. Okay, so although this looks good, they may want to try and improve that to 90% next time. So it's always about trying to leave less and less and less patients behind. So in terms of the purpose of the outcome indicators, for the individual FLSs, it's to help them do their PDSAs and their continuing quality improvement. So that's useful to them personally. It's certainly to help improve the comparability of the data reported across institutions so that we're all talking, comparing bananas and bananas instead of comparing bananas and cucumbers. But of course, this is also to help the local FLSs because once you can compare your results with the other Canadian FLSs results, that will help you see, well, we're doing good for the first eye, but we really need to pull up our socks for the third eye, for example. And at Osteoporosis Canada, it's also to help us establish benchmarks. And by the way, this year for the Canadian FLSs, we are conducting the first national FLS audit. We hope that this audit will help us define where the FLSs are today. We'll be feeding that information back to the FLSs so that they can see where they're themselves, where they fit. In terms of are they above average, below average, that kind of thing. But at the end of the day, none of this is the purpose of the outcome indicators. The purpose of the outcome indicators is actually to help improve the outcome of the patients. And in fact, what we're looking at is to change this pie chart. We want to start to see less and less and less and less of that purple. And we want to see more of the blue and more of the yellow. So this is all to help the fracture patients in the end. So at this point in time, I'll entertain your questions. So Luann, if you want to, I don't know if you see the questions or I see the questions in the chat boxes.
Yes, we can both see them. I just put a message there. If anyone has any questions, you can type them into that chat box. If you also, there's a spot in our survey that you'll receive at the end of this webinar that you can put any questions in. But if you ask them now, Diane can respond to them immediately. So we'll give you a few minutes to type up and think up some questions and hang on here for another 3 or 4 minutes and see what happens.
Well, I don't see any questions coming up. I think we'll give it 1 more minute in case somebody's typing slow.
Agreed. Thank you, Diane. That was very informative. I'm sorry that we had any technical difficulties. We did lose one person along the way who may or may not have left because of that, but hopefully we'll also have this webinar recorded so people can rejoin it once it's archived on our website. So that will be there probably within a week or so.
Okay, so thank you very much, everyone, for attending. And please fill out our evaluation form, which you'll be getting shortly.
Thank you, everyone.
Thank you.